Okay, here we go, the central versus peripheral visual field at the first introduction, and then we'll delve into the Amsler grid for central visual field testing. Basically, Amsler grid is very important for clinical cases, especially. We definitely prescribe Amsler grid to patients like ARMD and all these things. So let's discuss what are the 7 types of this Amsler grid and all. So first, visual field. As I have already discussed, the portion of the space in which object visible during the steady fixation of the gaze in one direction. It's very important whenever you describe the visual field, you have to mention the steady fixation in the gaze. And that particular gaze, you will see the portion of the visual space where you see the objects. That's a visual field basically. So normal limits of the visual field, as I have already discussed, inferior retina, which is 60 degree, actually superior visual field, and superior retina, inferior visual field, which is 75 degree, and most the nasal retina, so largest visual field temporally, and nasally because of the temporal retina, which is around 60 degree. So macular central is 10 degree, and the foveal approximately 2 degrees, but sometimes I don't know. Visual field is limited size retina and margin of the orbit, because in the size of the retina and the margin of orbit, how bone grows and all these things, isn't it? Visual field is limited by this. But whenever we talk about central visual field, we will talk about 30 degree from the fixation point of view, isn't it? It's very important. Whenever we talk about the central visual field, we are talking about 30 degrees uh, from the fixation, and contains physiological blind spot also, isn't it? Physiological blind spot also. So at fovea, around is in foveola, it's 0 degree, and then off centers. So paracentral phobia is 3 degrees, not less than 1 degree, and paramacular 5 degree, not less than 3 degree. These are the some definitions of the all things. Peripheral field of view is a rest of area that beyond 30 degree to the outer extent of visual field. Okay, the 30 degree from center, it's called center, and then it's called central visual field. Then away from that, it's called peripheral visual field. Okay, so peripheral field can be examined by kinetic perimetry, as I have already discussed with the Goldman perimetry is very good. So temporal field constrict with the age after the sixth decade. Yes, we know that with old age, the temporal visual field also constrict, and even the visual sensitivity also decreases. Automatic peripheral decreases sensitivity. It shows the sensitivity decrease, and causes is partially age-related miosis or peripheral cataract, cortical cataract, or decreasing oxygenation in the periphery of the retina. This can be the causes of decreasing sensitivity and even temporal visual field restriction. So it shows that I4E decrease rate is 6% per decade, and with I3, as we have already discussed in Goldman, 8% per decade, I2 10% per decade. That actually decreasing what? Decreasing temporal visual field. So visual field screening, central and periphery. What is central and what is periphery? So in case of central visual field screening, we talk about visual acuity. Yes, it's very simple, but definitely Amsler grid with still 20 degree of visual field. Tangent screen also is any back central visual field test also be done. But whenever we talk about periphery, we talk about periphery like confrontation, which is most easiest and important way of examining periphery. Perimetry, which is basically nowadays we can do perimetry from Humphrey peripheral screening, and very good peripheral screening is definitely sorry, not Amsler green, but um, Goldman perimetry and arc perimetry. There are a lot of things that we can normally do, but in clinical practice, yes, definitely Amsler grid is very useful for central visual field defect, isn't it? So there are some terms in visual field defect that we have to discuss. So first, central fixation only. If there is central visual field defect, it means centrally fixating area, isn't it? This is a blind spot. Psychocentral, this term is very important term. It's actually visual field defect from fixation temporally to the blind spot. So basically, psychocentral means central and blind spot when you're connected, and it's called psychocentral. Paracentral, it's very simple. Region next to but not including fixation. Paracentral defect means not including fixation is good, fixation point is, but the nearby fixation point, if there is any visual field defect, is called paracentral. At the same time, pericentral, the region symmetrical surrounding but not involving the fixation, is called pericentral. Okay. Arcuate, as a name suggested, is an arc, isn't it? Corresponding to the two and the representation of nerve fiber bundle, because nerve fiber bundle also, for example, if this is an optic nerve head, this is blood vessels, nerve fiber layers also moves like it's arc, isn't it? And this is horizontal superior arcade, and this is inferior arc. Same like this is the picture in arcade fashion, isn't it? This is the lower arcade. In superior arcade it forms. If lower and superior arcade meets, then it's called totally round visual field defect, isn't it? So altitudinal defect. Altitudinal means one half, either superior or either inferior, like altitude, like height. It involves two quadrants, either superior or inferior quadrants. That's altitude. Quadranopia means pie in the sky, pie in the floor, like one quadrant out of four, isn't it? One quadrant out of four. So that's quadranopia. So let's move to the directly Amsler chart. Okay, so central, not central visual field, all the central visual field defect, but the Amsler grid. Let's talk about the Amsler grid. Amsler grid, named after Dr. Mark Amsler, 1920. So manually compromised seven charts. Actually, Amsler grid means there are seven charts. Yes, first chart is the most standard chart, but definitely there are other six charts. So each chart has a dimension of 10 into 10 centimeter square shape, which means 100 centimeters square area. So the Amsler chart must be held at 33 centimeter. It is very frequent question in MCQ. Okay, must be held with the working distance or whatever viewing distance 30 centimeter. If you put 100 centimeters square card at 30 centimeter distance, this is 30 centimeter, then actually it covers 20-degree central visual field. Okay, at that point, what how much visual field will cover? 20 degrees. That's why it's called central. So correlating area just inside the temporal vascular arcades, not including optic disc. That's why Amsler grid doesn't include blind spot, because it doesn't include optic disc. Okay, important in testing macular function, central important. Okay, I'll make another video with macular function sensitivity, macular function test uh, videos, but I will definitely going to talk about that. But today we are going to discuss about Amsler grid in detail. Okay, indication for testing: definitely reduce best corrected visual acuity even with the pinholes. Yes, even with the pinhole, then we will suspect always media opacity or macular changes or optic nerve head changes. Pathologically suspected macular disease, yes, definitely, like for example ARMD and all these things. Abnormal color vision, which is very likely that it may be optic nerve defect or macular defect, but yes, moreover optic nerve head defect. Suspect appearance of macular area. If we suspect the appearance of in abnormal appearance in macular area, then we test by Amsler grid, even prescribe to the patient. Okay, the very first Amsler grid chart is basically a standard Amsler grid chart. Okay, so basically first Amsler grid chart, there is 7 Amsler grid chart. First is standard and first is very familiar and widely used. And grid pattern consists of 0.5 centimeter wide white square set against the black background. See, I want to emphasize this. Many of the students think that the line is black and background is white. No, that's wrong. The line are white, background is black. It's very important. Second point that very important is this. The spacing is 0.5 centimeter in a standard, definitely in a standard. Okay, so basically 0.5 centimeter space corresponds to visual area of 1 degree. It's very important. See, 10 centimeter, and if you break it into 0.5 centimeter, isn't it 20 lines and spaces box? That 20 box, each box corresponds to 1 degree, and that each box corresponds to 1 degree means 20 horizontal degrees, 20 vertical degrees, isn't it? That's why absolute grid always correspond to 20-degree visual field. Okay, fine. It always came in the MCQ. What is the distance between two lines in normal standard? So this is the chart. Background is black. Yes. Lines are white. Yes. Most versatile and used to identifying various form of distortion in the visual field, relative and absolute scotoma. As you have already discussed, absolute means pitch black dark, relative means not pitch black dark, definitely with respect to the seeing area. Chart 2. What is the difference between chart 1 and chart 2? Whenever you see another chart like chart 2, chart 3, chart 4, chart 5, always try to contrast with the chart 1 and the other as I presented. Okay. So, patient with the central scotoma may respond better with the chart 2. Why? Similar to the standard grid chart, except only one thing is added in chart 2, that's diagonal line intersecting the central area of the grid form X, means this. Only diagonal central area, central X is different, giving patient for better idea whether to fix. So this central X help patient to know whether to fix, because this X naturally draws us that X will going to meet somewhere in there. If there is central scotoma, then it will helpful to patient to fixate on the chart. Okay, the larger white central spot, see, white central spot may be applied with a tap of the center of the grid if the patient is still unable to achieve the maintained central vision. So basically it is applied if patient is not unable to visit. So just difference between uh, chart 1 and chart 2 is just this big cross. Remember that this cross is also with a white line. Okay, fine. Chart 3. What is chart 3? Configuration for identical with that of the standard. Everything is identical, but only difference. But red is squares instead of white. Okay, that's the difference. Everything is same, black background, but whenever this white lines in third chart, there is a red lines. That's the difference. Why red lines? Because red lines stimulate long wavelength cone found predominantly in the phobia. So basically, foveal cone predominantly stimulated by the red wavelength. That's why we do red. Just remember this. Okay. It's useful for the patient suspecting the central or centrocecal scotoma or associated with especially nutritional amblyopia. Okay, thalamin defect, alcohol poisoning, isn't it? So toxic maculopathy from quinine derivatives and evaluation of the color scotoma and desaturation. It also helpful. So that's why it is used in these regards. Chart 4. What is the difference in chart 4? No line to distort. So in chart 4 there is no line. Finished. Instead of small white dots randomly distributed over the background. Let me show you. This is chart 4. Is there any line? No. But random white dots, okay, in black background. Patient with one or more paracentral scotoma may be able to delineate the areas of involvement more easily. We think that if there is scotoma, then patient can distinguish because these white dots will vanish, isn't it? Because of this scotoma. Since the background in the scotoma appears the same color for the observer, it may result in the false result. It can be result as a false result, but we hope that somewhere where there is no white seen by the patient because this is hidden by scotomas, then patient can recognize there is a scotoma because I can see whites there. But sometimes these features of the chart 4 it also cause they cannot find any scotoma because it's random and everywhere. But let's not go into it because we hope that chart is constructed for this and it works. But I haven't used chart 4 in my career, so I cannot say anything. But this is the concept basically. Okay. Chart 5. What is the difference in chart 5? So only chart there no lines in chart 4. Just remember. Okay. Chart 5. Then 20-degree evenly spaced horizontal line on the black background. So there is only horizontal line. Okay. So let me show you first. This is the okay. 20 lines, same white lines in black background. It's possible to relocate the chart at any meridian to check the irregularity in the particular area. Since we can shift it, isn't it? We can make in this line, or we can make this because shifting this or reorienting chart. So it's simple. The patient with the central and paracentral metamorphosia due to various retinal and choroidal disease is especially sensitive. So this is the only very useful thing for this. Central paracentral metamorphosia. In case of metamorphosia means somewhere these lines gets wider, somewhere this line gets smaller, so there is nothing uniform. So that's all about chart 5. Chart 6. So what is the difference in chart 5 and chart 6? There is very slightly difference between chart 5, okay? But the only difference, it contains black lines against the white background, which is always there. No, which is not always there, isn't it? This is the only chart in which you see white background in black line. And there only one thing, see, only one background is white, line is black. One extra thing is this, isn't it? There's few more lines. So one extra thing, the area 1 degree above and below the fixation dots bisects an additional horizontal line. So actually it's area 1 degree above, area 1 degree below has other horizontal lines too. Isn't it? That's the difference. So chart 6 is actually only chart in which background is white. Okay. So metamorphosis along the reading level. Why? So see, metamorphosis can be diagnosed by the fifth chart, but why we put extra lines? Because we want metamorphosis seen at the reading level, maybe more easily observed with this chart. It's a very important line for this chart. Okay. Chart 7, the final chart. These charts break the horizontal orientation 6 into 8 degrees central area. Okay, remember this. And corresponding anatomies to normal macula with into 0.5 degrees squares. How much degree this squares normally we have? 1 degree, isn't it? Then we, in this particular area 6 into 8 degrees, we put more lines. Okay, why we put more lines? Making it more sensitive to detect insidious macular compromise. It's very small macular compromise we can detect, so that's why we put extra lines in this 6 into 8 degrees. The more useful in cases where there is subtle visual disturbance from the macular disease, especially early in the course of disease. So that's why it's used early in the course and very subtle, very insidious macular problem. See, I have to. This is the area 6 into 8 degrees area, and we put here extra lines. See, this is space between one two line is corresponding to 1 degree, but if you half it, it corresponds to 0.5 degree. That's the concept. And 0.5 degree in this area 6 into 8. Okay, so what is the clinical procedure of Amsler and grid? Clinical patients should be wearing appropriate correction distance for the test. For the test means 33 centimeter, isn't it? So for 33 centimeter, it means patients should wear near correction if he has. Okay, so no lights should be shown to the patient's eye before the test, because people is constricted. So, and another thing, patients should not, people should not be dilated, and no lights should be thrown into the patient, because if we throw light into the patient, then what happens? Because of glare, there is difficulty. Okay, charts should be uniformly illuminated, otherwise it will be very difficult to examine patients. So there is 5 series of questions that we can ask according to books. Okay, so first is, can you see the central white dot? Because we want the central fixation, if there is central fixation or not. The rule out the central scotoma. If yes, the central scotoma unlikely unless false positive response or due to poor patient compliance. Okay, if patient compliance is not good, that's false positive. Otherwise, yes, there is central fixation. If it's look washed out or it seems slightly blurry, then suspect the relative central scotoma, not the absolute, but the relative. Okay. First questions. This is central scotoma if it's present. Okay. If the patient is unable to see the center white dot at all, the absolute central scotoma may be present, because it's relative central scotoma, this absolutely dark central scotoma, isn't it? If patient cannot see the central dot there is central dot he can exactly put on. So second question is, can you see all 4 sides of the large square as well as all 4 of its corner? See? To rule out the arcuate or altitudinal quadratic or hemianoptic field defect as well as overall field construction. It means like this. If they cannot see this area, isn't it? It's arcuate defect, can be the arcuate defect, isn't it? The arcuate scotoma is seen in advanced glaucoma. So if they can see four corners and four these corners of the even chart and of the whole chart or of the absolute grid only, it's very important. So if yes, then we will proceed to 3. If no, then patient should be asked to document the missing side of the corner as accurately as possible. So which again help us to slightly build up where is the problem. So which is very useful question. Okay. So third question, are any of the small squares blurry or missing out on any part of the grid? So what do we want to know there? We want to rule out the relative or absolute paracentral or secocentral or altitudinal scotoma. Is there anything in this area like something like that? Isn't it? If no, then we proceed to the question number 4. If yes, initially rule out the false positive response. Sometimes patient gives a false positive. We have to ask again. If patient is not properly corrected, or if media opacity created a blurry or a doubling of the horizontal or vertical line. Sometimes there may be monocular diplopia, isn't it? By early cataract and everything. So it's very possible. Then fourth question, do any of the horizontal or vertical line that makes off the square appears wavy or bent? Can't you see? The line should be straight, but if there is anything like wavy means there is a chance of metamorphosis, isn't it? There is a chance of distortion. So metamorphosis, it's very important. So you want to ask about the squares or lines are bending or wavy like. Okay, it's very important question. If no, so then we proceed to the question number 5. If yes, then clinician must initially rule out the false positive. It's very important. Patient asks how that waving is going on, how there's bending is there, uh, asking patient about being particular. Okay, if the patient is looking through the line of multifocal segment, he or she wearing or noticing the peripheral distortion or the progressive addition lens, isn't it? Progressive addition lens, or there is multifocal segments, or even patient with a high negative power minus lens spectacle, high plus lens. This spectacle itself can create distortion, isn't it? And that's very important that you understand these things and try not to this patient instruct the patient to see through the optical center. It's very important. So this is the central metaphor. Say this is isn't can't you see the waviness of the line? And this is called macropsia, the central field largest. The pathology of macropsia is very important. The space occupying pathology that forces the cone closer. If cone, for example, if there is a cone like this, okay, lot of cones, and because of the space, the cone space are synchronized in a very small space. At that particular case, we see macropsia. Okay. At the same time, if because of the pathology the cone cells just goes apart from each other, then it will call micropsia. So basically this, okay, micropsia means seeing small, and in that case particular macular edema or pathological forces cone to move apart. At that particular case patient see micropsia. Okay, at last, is any part of the grid is smearing, flickering, or colored to rule out the oscillating scotoma? Sometimes it's like flickering. If no, the series of questions are completed and can be expected to have normal visual field. If yes, may herald the onset of scotoma of the retinal origin, and particularly if early serious or hemorrhagic detachment is disrupt pathological retinal topography. In that case, some flashes can be seen, or sometimes scotoma comes and sometimes goes. It can be happen. Okay. So now, how to dispensing the Amsler grade? First category, patient with a progressive disease. It's very important. For example, the common thing ARMD, isn't it? So it's very important that patient has a progressive disease. Then we dispense Amsler grid to the patient. Patient will take Amsler grid to home and test himself. So toxic maculopathy or typical retinitis pigmentosa field defect start from the central, isn't it? In that particular case, predisposed or develop significant alternation in function of the vision overall time. Secondary category is patient with active disease such as optic neuritis and macular neuropathy. At that particular case, whose visual acuity may improve or worsen with relative short time span. In this case, we dispense Amstel grade. Third category, patient with a recurrent disease such as central serous retinopathy or toxoplasmic retinochoroiditis. In that critical case too, we dispense. Why? Because who may have already suffered the vision loss and risk experiencing the reactivation of the disease. That's why Amsler grid is there at a particular home, and they watch themselves. They, whenever they suspect, and if they can detect anything, they can definitely move to his ophthalmologist. So ARMD, this is the picture of distortion. Okay, so basically these are the things. Okay, so we have the great book here for all the references, but yes, definitely clinical procedure of optometry is another good book. Okay, Bistan, choose.